আমাদের লাইভে আছে।
মতিন ভাই আমরা লাইভে।
সুপ্রিয় চিকিৎসকবৃন্দ, আসসালামু আলাইকুম। আপনাদের সবাইকে আজকের বিডি ফিজিশিয়ানস এর আয়োজনে স্বাগতম জানাচ্ছি। আমি ডাক্তার মোহাম্মদ আব্দুল মতিন, কনসালটেন্ট কার্ডিওলজিস্ট, 250 শয্যা জেনারেল হসপিটাল ফেনী। আজকে আমাদের মাঝে উপস্থিত আছেন স্বনামধন্য স্পিকার হিসেবে আমাদের এই সবার শ্রদ্ধেয় ডাক্তার রফিক আহমেদ স্যার, কনসালটেন্ট ইলেকট্রোফিজিওলজিস্ট, ওয়েলস্পেন মেডিকেল গ্রুপ কার্ডিওলজি, গেটিসবার্গ, পেনসিলভানিয়া, ইউএসএ। স্যারকে নতুনভাবে পরিচয় করে দিতে হবে না, কারণ স্যার আমাদের এই আয়োজনে অনেকগুলো লেকচার আমাদেরকে দিয়েছেন, আমরা অনেকগুলো সমৃদ্ধ হয়েছি। স্যার সুদূর প্রবাসে অবস্থান করলেও স্যার অন্তপ্রাণ মননে মস্তিষ্কে সবসময় দেশকে লালন করেন। স্যারের হাত ধরেই বাংলাদেশে কার্ডিয়াক ইলেকট্রোফিজিওলজির যাত্রা শুরু হয়েছে এনআইসিবিডিতে। আজকে আমাদের মাঝে আরো উপস্থিত চেয়ারপারসন হিসেবে উপস্থিত আছেন প্রফেসর ডাক্তার আব্দুল ওয়াদুদ চৌধুরী, বিভাগীয় প্রধান, ঢাকা মেডিকেল কলেজ হাসপাতাল। স্যার হচ্ছে, আমি মনে করি স্যার হচ্ছে আমাদের কার্ডিওলজিস্টদের প্রফেসর। বাংলাদেশে বর্তমানে যে সমস্ত কার্ডিওলজিস্ট কর্মরত আছে, আমার মনে হয় সকল কার্ডিওলজিস্টই ধরতে গেলে যারা স্যারের থেকে কম বয়সী সবাই হয়তো স্যারের ছাত্র, এবং যারা আমাদের বয়সী আছে তারা সবাই হয়তো স্যারের হাত ধরেই কার্ডিওলজিস্ট হয়েছেন। তো আজকে এই দুইজন লিজেন্ডকে আমরা যদি আমাদের এই প্রোগ্রামে পেয়েছি, যেই আজকের যে টপিকসটি হচ্ছে সেটা হচ্ছে অ্যাট্রিয়াল ফিব্রিলেশন এন্ড অ্যাট্রিয়াল ফ্লাটার ফ্রম ইসিজি টু ম্যানেজমেন্ট। আজকে এই দুইজন লিজেন্ডের কাছ থেকে আমাদের শিখতে পারাটা আমাদের জন্য অনেক সৌভাগ্যের বিষয়। বিডি ফিজিশিয়ানসের যারা শ্রোতা তারা হচ্ছেন অ্যাজ ওয়েল এজ একাডেমিশিয়ান, অ্যাজ ওয়েল এজ যারা জেনারেল প্র্যাকটিস থেকে আরম্ভ করে স্পেশালিস্ট ক্লিনিক্যাল প্র্যাকটিস করে। অ্যাট্রিয়াল ফিব্রিলেশন ওয়ান অফ দি মোস্ট কার্ডিয়াক অ্যারিথমিয়াস, যেটা আমরা একদম রুরাল থেকে আরম্ভ করে সকল জায়গায় চিকিৎসা করতে পারি। ইভেন কি রুরাল এরিয়া তো 99 to 100% কেস ম্যানেজ করা সম্ভব। তো আজকের এই আলোচনার মাধ্যমে, আজকের এই ওয়েবিনারের শেষে আমাদের জ্ঞানকে আমরা আরো সমৃদ্ধ করতে পারবো। তো আমি আজকের এই প্রোগ্রামটি শুরু করার জন্য আমাদের সম্মানিত চেয়ারপারসন প্রফেসর আব্দুল ওয়াদুদ চৌধুরী স্যারকে উদাত্ত আহ্বান জানাচ্ছি। স্যার।
আসসালামু আলাইকুম, সবাইকে শুভ সন্ধ্যা। আজকে আমরা অ্যাট্রিয়াল ফিব্রিলেশন, অ্যাট্রিয়াল ফ্লাটার নিয়ে কথা বলবো। এই যে হার্টের ধুকপুকুনি যেটা খুব অনিয়মিতভাবে চলছে, এটি যে কত ডেভাস্টেটিং হতে পারে সেটা ভুক্তভোগী যারা জানে, যারা দেখেছে তারা অনুভব করতে পারে। এটা প্রপার ম্যানেজমেন্টটা যদি আমি করতে পারি, রোগীর অনেক ভোগান্তি আমি কমিয়ে দিতে পারি। আজকে রফিক স্যার, আমাদের সবার প্রিয় রফিক স্যার, সেটা নিয়ে কথা বলবেন। আমি আর কথা না বাড়াই, স্যার এখনই হয়তো শুরু করবেন।
Assalamu alaikum. Good evening, and again, thank you, BD Physicians, for inviting me for this talk. So today, normally I do mainly ECGs, but I thought this is an important topic. ECG is important, but I think the overall the management is so important that we need to talk about it. And this is, I found a book published in 1918 by Sir James Mackenzie. And what they did in those days, the younger physicians probably don't know this, but most of the ECG diagnoses were made before ECG came out. And these were by venous tracing. So what happened? They did venous tracing in normal people, and you can see the A contraction is from the atrial contraction. This is the ventricular contraction, and then this is the venous phase, and you could see A, C, and V. And then they found patients with irregular heartbeat, and they found that there is no A wave. So they thought the atrium is paralyzed, and that's why it is to be called paralysis of auricle. That was the initial diagnosis term used for atrial fibrillation. And he also noticed something, that auricular fibrillation, it can cause exhaustion of the heart by overstimulation. That was used at that time, and that the slowing, and they used digoxin at that time, enables the heart to get more rest, enables it to regain measure of strength. I mean, it's an amazing statement made before echocardiography, before ECG. And these are really, really talented physicians that did this. And historically, you will also find a physician, there is a person called Shamroth from South Africa. He described electrophysiology before electrophysiology was there, and mechanism. So please read those histories. So what happens? This is an ECG. You can see that there is a normal sinus rhythm. We have in lead 2, we can see the P wave, PR interval, QRS complex, normal 12-lead ECG, and a regular RR interval. So every ECG, there is a P wave followed by QRS, P wave followed by QRS. As opposed to this one, Jason, do you think we should have somebody, or I should just continue the talk?
Sir, you can have somebody, sir, no problem.
Sure. So let's have one person to answer this one.
Anyone can raise his or her hand.
কেউ একজন হাত তুলে এটার আনসারটা দিলে ভালো হয়, কানেকশন হয়ে।
Okay, Dr. Sara Al Raji.
Assalamu alaikum, sir.
Well, so the heart rate is 72, and you go from there.
Yes, sir. This is the 12-lead ECG showing heart rate is about 72, but
Yes.
rhythm is irregular, and P wave is absent. QRS complex is narrow, less than 120 millisecond, and there is some fibrillatory wave present in lead V1. In case of 1 and AVL, 2-3 AVF, there is irregular rhythm, but no ischemia. But V1, there is RSR pattern, that is right bundle branch block. In my diagnosis, it is atrial fibrillation with rate control rate.
Oh, perfect. Thank you. So that's an excellent description of this ECG. Basically, when we look at this ECG, there is the RR interval is irregular. That is striking. Secondly, QRS is narrow. So it's a supraventricular rhythm, and there is no definite P wave. If you look at V1, you can see these fibrillatory waves. Now, in this one, you can see the fibrillatory wave. Sometimes it's difficult. Look at lead V3. Looks like a P wave, but this is not. Sometimes in some of the leads, you can find these discrete waves, and people can confuse it as sinus rhythm, but it is not. If you look at lead V1, there is no. And if you look at in the lead 2, you can see the fibrillatory wave. And there is right-sided conduction delay, but without really, I'm glad that you pointed that out. It is not right bundle, but there is definitely. I was wondering whether I should mention this, but you mentioned it. Because there is terminal S wave in lead 1, and there is RS, little bit RSR, not real typical RSR, but there is right-sided conduction delay without right bundle. So this is atrial fibrillation with probable right-sided conduction delay. So please stay with me. So how about this one? Just give me a quick diagnosis. Heart rate is 122. Is Sarah gone? It's fine. So here, the heart rate is 122. Again, if you look at it, it looks clearly irregular RR interval with a narrow QRS. And in lead V1, you can see these waves, which are no definite P wave pattern. Sometimes people confuse this sharp signal as flutter, but it's not. It's basically fibrillation. Things sometimes can get a little difficult here. If you look at this ECG, if you look at narrow portion, it looks almost regular. But if you look at a longer strip, you can see the irregularity. That's why when the rate gets faster, you may need a longer rhythm strip sometimes to diagnose atrial fibrillation, to notice the irregularity of the RR interval. Can anybody do this one? This is a rhythm strip.
কেউ একজন হাত তুলে বলো।
Okay, sir, Dr. Buddhudev Ganguly.
Namaskar, sir.
Namaskar.
Sir, yeah, it is the ECG of the third lead, not wave lead. Heart rate approximately 150. So, and short root appearance is V1, lead 2 and lead V5. My DX is atrial flutter is to 2:1 conduction.
Perfect. Beautiful. Thank you. So basically, this is a narrow QRS tachycardia. Rate is a little bit over 150. But at that range, you first think of atrial flutter. And one of the lead to look at is lead 2. You can see where my pointer is. There is a negative P wave. There is another negative. And I think this is another negative. So it's basically a typical atrial flutter with 2:1 conduction. Sometimes this can be confused with SVT. If you look at lead V1, you see where my pointer is, there is a P wave, there is a second P wave here. So you can see both P waves. But having a degree of suspicion, and the difference between that one and this one is that it's very regular. And of course, when atrial flutter gets regular, slower, you can see the flutter wave in this case, like white QRS left bundle type ECG with atrial flutter. So as opposed to fibrillation, this is a regular rhythm. So how does it happen? I mean, this is a very gross picture. Atrial flutter is a big macro reentry. It's a circuit. Normally in the right side, sometimes we can be, and that produces the typical flutter wave morphology. Fibrillation, on the other hand, is a multiple wavelets all over the atrium, producing this fibrillatory wave. So mechanistically, they are different. And so treatment-wise, they are also different. Like, so if I want to take care of this circuit, I can ablate it, or I can give a low energy shock to stop the circuit. But to cardiovert this one, you need higher energy shock to convert all these bits. And the other thing that happens mechanically, that in flutter, there is contraction of the atrium. But in fibrillation, there is so much disarray of electricity that mechanically the atrium is not contracting at all. Why do we get atrial flutter? Most of the time we don't know, but there are few things, like you can have hormonal problem, mainly thyrotoxicosis, or conditions like pheochromocytoma. At that situation, it can happen. Or somebody comes to the hospital with severe pneumonia, or let's say COVID pneumonia, they can have atrial fibrillation. And then there is another group, older patients. And we are now finding out that we have more and more patients we are diagnosed with amyloidosis. Now there is technology, so we are finding that there is infiltrative cardiomyopathy that's causing amyloid. And then of course there is atrial scar. It can happen after myocarditis, atrial infarction, post-atriotomy, those kind of things. And then atrial stress, such as mitral stem, mitral regurgitation, all this kind of. But this, you can read about it. Majority of the time, we cannot pinpoint a diagnosis. But one of the diagnoses that we always need to exclude is thyrotoxicosis, because if we cure thyrotoxicosis, atrial fibrillation will go away. As it was mentioned by our introducer, that if you look at this, atrial fibrillation actually is the commonest cardiac arrhythmia in clinical practice, and everything else is less. So this is a huge picture. In America, as the population, you see the age, these older patient, smaller number of older people, they have the highest burden of atrial fibrillation. And this same thing will happen in Bangladesh. The good thing about United States and Bangladesh is that any statistics in the United States, if you have, it becomes the incidence in Bangladesh. So in USA, expected number of atrial fibrillation cases by 2050 will be 5.6 million. That means in Bangladesh, we'll have at least 2.5 to 3 million cases of atrial fibrillation by 2050. And that will be a huge burden that we need to take care of. Please remember, these are the diseases, chronic diseases, that in the past we did not take care of them because of very reasons. People didn't come to the hospital. We did not have the economic ability. And I can guarantee you, and I'm hopeful that by 2050, Bangladesh will be like any Western country, developed country. And so we have to prepare ourselves for the future. And you are the generation who will actually see to 2050. We do not know whether we will stay there. But you will be dealing with these patients, and with higher technology, higher economic ability, and you should all prepare yourself for the future. So forms of atrial fibrillation, paroxysmal. That means something that comes and goes. So if I have a patient, I do a Holter monitor, I find that there is a few episodes of atrial fibrillation lasting less than 48 hours, I'll call it paroxysmal. Persistent atrial fibrillation, episode that lasts more than 48 hours, which can still be cardio, but the other one that we have, if I have a patient who have never undergone cardioversion, even if they have atrial fibrillation for more than a year or two, I'll still call it persistent, but not permanent. And the permanent will be that we have tried everything and we still cannot maintain sinus rhythm. That's permanent. And these are the three definitions that has been accepted universally now. And of course, the causes can be cardiac causes, non-cardiac. And there is a group of patients we call lone atrial fibrillation. That means we cannot find any diagnosis of atrial fibrillation etiology. And those are probably a small number of patients. Lone atrial in the absence of identifiable cardiovascular cause, and approximately about 2%. And I'm sure what's happening that even though we call them lone atrial, sooner or later we will find a cause for this. Of this, and there are genetics coming into play. There is imaging modality coming to rule out infiltrative disease that can cause atrial fibrillation. So what is the problem with that? The main problem of atrial fibrillation, which is a devastating thing that Professor Wadud mentioned, that embolism and stroke. This is a devastating. If you have never seen a patient with stroke happening in front of you, you will not know how bad this is. When patients come with stroke and we see the patient in stroke. But if you have seen a patient the day before, they were normal, and next day in front of your eye suddenly cannot move their extremities, then you realize how devastating that thing is. And the other thing is that if I have a choice between getting heart attack and a stroke, I will take the heart attack rather than stroke, because heart attack I either survive or I'll die. But with a stroke, I'll survive and live with this disability for the rest of our life and my life. And that's why it's so important to understand this risk. And then, of course, it can cause acute hospitalization because of the symptom. Patients can develop congestive heart failure because of rate-related cardiomyopathy. And then most patients have some chronic symptoms. Some patients will say, Doctor, and they can tell the difference. When they're in sinus rhythm, they feel fine. And when they're in AFib, they just don't feel well, lack of energy and vague non-specific symptoms. And that's why we have been emphasizing in all the forum that talking to the patient and the clinical scenario of the patient is very, very important. And asking the patient that, how do you feel? And let's say I cardiovert a patient and goes to normal rhythm. When he comes back, he goes back, let's say he has come back and he's back in atrial fibrillation. I always ask, did you feel better when you were in normal rhythm? They said, yes, Dr. Ahmed, we felt better. Sometimes they cannot describe the symptom, but they have this sense of well-being. So these are the chronic symptoms that are important. What is the risk of stroke? Across the board, it's about 5 to 8% risk of stroke in atrial fibrillation. And then this is what happens. This is a bigger clot. If it's an autopsy specimen, that left atrial appendage, there is a clot here. And some of these minor, small things can dislodge and cause stroke. But not all of them are big. Look at this one. This is an autopsy specimen, and you can see a small 5-millimeter clot. And it can be much smaller clot that can dislodge and lodge into one of the cerebral arteries and cause stroke. And this is what can happen, that you can go and it lodge in the distal artery and cause stroke in the area. And this doesn't have to be a big clot. It can be a 1-millimeter clot and cause TIA or manifested stroke. So is it really related? I'm going to show you some old data. If you look at, these are from Framingham study. The green is patient without atrial fibrillation. And you can see across the age group, without atrial fibrillation, the risk of stroke is much lower than with atrial fibrillation. And this is very, very clear. This is a very old study. And same thing, that when they looked at risk, I'm going to come back to this risk factor. This is a very old data of risk factor. But I'm going to come to this just to show you that when people have risk factors, so patients without risk factor and with risk factor in atrial fibrillation, when they have risk factor, more than one risk factor, a significant increase in risk of stroke. And of course, that with age, the risk of stroke goes up across the board. So two factors. One, as we grow older, the risk of stroke goes up with atrial fibrillation. And if there is additional risk factors, then risk of stroke goes up proportionately to that. And there are, so again, same thing, I'm re-emphasizing there is a control group and what they did, and then patient received warfarin. So if this study showed that with or without risk factor, anticoagulation reduce the risk of stroke. These are old data, and I'm not going to run on this, but I'm going to go back on that. Warfarin, the reason we bring up warfarin, has been the gold standard for many, many years. And multiple studies were done to look at benefit of warfarin. And if you look at here, that the studies were across the board, high dose warfarin, INR just over 2 to 4.5, INR between 2 and 3, and some studies included, like here, SPAP3 study, low dose warfarin to see if there is any beneficial. So, and what they found out that across the board, aspirin is superior to no warfarin in reducing risk of stroke. Look at this study, and I'm going to go back. I'm going to look at only this study. There is some overlap. There are some patients, bigger district, but still the median was improved. So when the INR is therapeutic, warfarin reduced risk of stroke, and aspirin is beneficial, but not as much as this is actually pooled data. These are not really specified, but if you look at low dose aspirin, and so the people always ask, how about low dose aspirin? The fixed dose INR 1 point plus aspirin in high risk patient, and you can see if combination group which received low dose of warfarin had higher risk of stroke as opposed to patients who had therapeutic warfarin. So no question that the data regarding use of warfarin within therapeutic range of between 2 and 3 reduce risk of stroke. And all the subsequent studies, the drugs that we have apixaban, rivaroxaban, or dabigatran, those drugs have been compared to warfarin as a gold standard. And those drugs have been found to be non-inferior in reducing risk of stroke. So this is the scoring system that we use now as VAS score, CHADS-2 S2 VAS score. And what it stands for, congestive heart failure, we're talking about systolic heart failure, score of 1, hypertension, score of 1, age over 75 gets the score. I'm sorry, this will be a score of 2. I made a mistake here, it will be score of 2. And then diabetes, score of 1, and history of stroke, score of 2, vascular disease, 1, age over between 65 and 75 is 1, and then female sex gets 1. Now, interestingly, female sex has been used as a risk of stroke, but it is now considered as a risk modifier, not real risk of stroke. So I'm going to give it. So what is the risk of stroke? So if with the old CHADS score, if the score was 0, there is still 1.9% risk of stroke. But with the newer scoring, the beauty of the new scoring, if somebody's score is 0, their annual risk of stroke is actually 0, which is beautiful. And then 1 is 1.3. And as you can see, now, do I remember these things? No, but I have a picture of this in my iPhone. So every time I see a patient, I just open it. So that's the beauty of having technology, that when I started medicine, we had to remember these things, or we had to find a book to look at it. But so you can just take a picture of this and keep it in your iPhone. So what happens? What is the recommendation? This is the latest update from 2019 from American College of Cardiology. In male, if the score is 0, we don't need any anticoagulation. In female, risk of score is 1. That means they are female, they get a score of 1. You don't need anticoagulation. If in male, risk score is 2 or more, and in female, 3 or more, they get anticoagulation. And score of 2 in female, you make the decision. 1 in male and 2 in female, yes, you have to individualize. And most of the time we will use aspirin. So this, please remember this, female CHADS-VAS score of 3 or more, male CHADS-VAS score of 2 or more gets anticoagulation. Why am I starting this anticoagulation first as opposed to anything? Because this is such an important issue. in atrial fibrillation. And we are going to reduce a debilitating disease. So who to anticoagulate? Paroxysmal, persistent, and permanent atrial fibrillation, they should all be considered for anticoagulation based on chest to heart score. And atrial flutter should be considered same as atrial fibrillation. Why? Because a lot of these patients have combination of atrial flutter fibrillation. And I think the current recommendation is this: you consider both in the same category. Which anticoagulant? The current recommendation, newer oral anticoagulants preferred over warfarin, except moderate to severe mitral stenosis or mechanical valve. Very simple. So they made these recommendations before they used to be very complex. And warfarin should be used for moderate to severe mitral stenosis or mechanical valve. Now, if somebody has chronic kidney disease, creatinine is less than 15 or on hemodialysis, they get warfarin. So that's very simple. I think that you should all get that paper. It's a very, very simplified way of looking at it. And then anticoagulation, when we initiate the newer anticoagulation, we must check renal and hepatic function before initiation and annually, because you may have to adjust the dose or change the anticoagulation. And of course, anticoagulation should be individualized based on stroke and bleeding risk, as well as patient's preference. We ask patient, what do you want? And of course, the cost of the medicine is important. And we have to periodically evaluate the need for anticoagulation. Do we really need to anticoagulate? Let's say somebody is 60-year-old and we can prove that they're not having any atrial fibrillation at all. We may consider changing it. Now, there is important that we also evaluate bleeding risk. And please keep this in mind. There is a scoring system, has bled score, and it has different scores: hypertension, abnormal renal function, stroke, bleeding risk, and each gets 1 point. And what do we do? If the score, has bled score is 1, bleeding risk is 1, 2 is 2, 3 is 4, 4 and more is 8% annual risk of bleeding. Now, any bleeding risk over 3, what we use it as, we take precaution that if somebody is on aspirin and clopidogrel, can we cut it down? If somebody has a renal impairment, we tell the patient about the bleeding risk. We do not avoid anticoagulation, and we keep better eye on the patient that if you have minor bleeding, get back to us. We check their hemoglobin, hematocrit on a periodic basis. So please keep this in mind. This is one thing that remember, and you can always take a picture of this and keep it in your iPhone or any smartphone. So newer anticoagulants, there are 2 ones, that rivaroxaban, apixaban, and dabigatran. In Bangladesh, we have these 2 available, and the preferences are the physician preference. I somehow like apixaban, twice a dose. I believe that probably is a little bit less bleeding risk, but that's not always true in every patient. So what do? We get a patient with atrial fibrillation. First thing, we have to confirm the diagnosis. Is it by ECG? Is it really atrial fibrillation? Or is it something that is looking like atrial fibrillation? Sometimes you have multifocal atrial tachycardia, which can look like atrial fibrillation. And is this paroxysmal or persistent? And then we do a clinical assessment of the patient. And we assess hemodynamic stability. And next determination is that somebody comes to the emergency, do I really need to admit this patient to hospital? Or can I manage this patient as an outpatient? And who should be hospitalized? Hospitalized would be clinically unstable patient, if they're hemodynamic unstable, having chest pain. And other issue is that if we feel that this patient will be better served to be anticoagulated in the hospital to initiate, that can be one reason to admit the patient. Rest of the patient can be treated as outpatient. If somebody comes with a heart rate of, let's say, 120, and they're stable, and I feel that the patient is reliable, I can start the patient on medication, I can always treat them as an outpatient. So what kind of blood work do we do? We, of course, do the routine blood work, chemistry, CBC, PTINR, and then thyroid panel is something that we always do in new onset atrial fibrillation. And there is a small number of patients, and these are important because that can actually make a big difference. you do ECG fib, all atrial fibrillation patients get a thyroid function test. Even if you don't do CBC chemistry, I don't think CBC is of much importance. Chemistry can be of importance depending on the electrolytes. And ECG, we can do a 12-lead ECG, which will show the diagnosis. If we believe that somebody has paroxysmal atrial fibrillation, and depending on symptom, we can decide on Holter or long-term heart monitor. Please remember about Holter. Holter monitor is the most done monitoring system, and if diagnostic yield is less than 1%. So if somebody is having symptom every 2 weeks, doing a 24-hour Holter is not going to help us at all. So we can actually decide how long we want to monitor this patient. Chest X-ray to rule out any gross abnormality, and of course, echocardiogram is a very, very important test to do in patients with Atrial. We always do echocardiogram because one reason is just to make sure that the heart muscle function is fine. Second, of course, valvular structure. But of course, you can always say that if there is any significant valvular disease, there will be some kind of murmur. Stress test is something that should be considered in these patients based on the clinical decision. If somebody is 65-year-old male with hypertension, hyperlipidemia, diabetes mellitus, we're not doing stress test because of the atrial fibrillation, because they do need the stress test at this age. What echo can identify structural heart disease, identify left atrial size, and sometimes we can see a blood clot in the left atrium in regular echo, and then we can do transesophageal echocardiogram that is better in ruling out atrial appendage, thrombus, or shadows. And just an example that if you look at this left atrial appendage, this is very clean, and you can see there is a clot. And I don't do transesophageal echocardiogram. My partners who do it, they do it all the time, and they can differentiate. Not all shadows like this are actually clots, or even if it is a clot, it can be organized clot. But I think one of the things that look at is the smoke in the left atrial appendage, which can be a precursor for thromboembolic event. We'll come to that. So what to do with these patients? So when we see a patient with atrial fibrillation, after the clinical evaluation, we decide whether they should be admitted or we treat them as an outpatient. First thing is to control the heart rate. Second, these two should go at the same time, anticoagulation. These are the two first steps, rate control and anticoagulation. And anticoagulation decision should be based on CHA2DS2-VASc score. And then, of course, next step would be restoration of sinus rhythm. And third would be how to maintain sinus rhythm. Rate control drugs, there are multiple drugs, digoxin, calcium channel blocker, beta blocker. We start with beta blocker or calcium channel blocker, depending on the patient's blood pressure and tolerability. Some patients have low blood pressure. It's difficult to start those medicines. And in those cases, what we do, we use a low-dose beta blocker or low-dose calcium channel with a digoxin. Digoxin is a fantastic rate control medicine. Only problem with digoxin, it does not control exertional heart rate. So, but people always are looking at data that, look, this is a horrible drug, but I still believe this is a good drug in well-chosen clinical scenario. And let's say somebody comes to me with AFib with RVR, blood pressure of 130. I start calcium channel blocker, diltiazem CD 120, blood pressure goes to 105. And the rate is still 110. I can't give any more beta blocker. I can add digoxin for a period of time, depending on the renal function. And then if we cardiovert the patient and maintain sinus, at that point we can discontinue the digoxin. So we have to keep that in mind that after cardioversion, once we have restored sinus rhythm, we should discontinue. And that's how we minimize drug side effect. And of course, non-pharmacological rate control will be AV node ablation. This is an extreme measure. We leave that for patients who have failed everything because we are making somebody pacemaker dependent. So we don't do many of these patients. We do few in a year. What is the optimum rate control? Resting heart rate less than 80 used to, or 6-minute walking less than 110. And some people say less than 110. And there is data on both. And I think nowadays, the data is if it is around heart rate of 100, is not too bad, depending on the patient's symptom and patient's myocardial function. I'm going to go with few cases. And this is a patient, the 33-year-old female developed palpitation for 6 hours, no chest pain, shortness of breath. She has no history of hypertension, no history of diabetes mellitus or stroke. So I want somebody to help me with this case. What are you going to do? Anybody from the audience?
Anyone can raise? Okay, Dr. Sajjad Hussain Rumel.
So, sir, Assalamu alaikum,
Yes.
sir. Sir, we can do
Sir.
an ECG at first to
Okay,
check.
fine.
Right.
You did the
Very
ECG. So this is the ECG.
Only 33-year-old.
Sir. So we can see, sir, this ECG has atrial fibrillation with fast ventricular rate, sir.
Yes, rate is 173.
Yes, sir.
So I'm
So
going to
we
go
can-
back to the. I'm going to go back to the slide. So no chest pain, no shortness of breath, but the rate is 173. What will you admit the patient to hospital?
Sir, in the emergency, we can try for the rate control, sir. And if there is
Okay.
no hemodynamic instability. So if we can control the rate, we can, after some times of observation, we can, and also we can need to check the heart to examine if there is any kind of murmur we can find or not, to look for the cause. And if we see that if there is no murmur and we have controlled the rate, we can discharge the patient with advice of investigation, sir.
Perfect. What investigation are you going to do?
Sir, I'm going to check for the serum electrolytes, the thyroid
Hmm.
profile, and
Okay.
also, sir, complete blood count to check if there is any loss, less hemoglobin, and on a routine, sir, urea creatine electrolytes and liver function test, sir.
Okay. And will you do an echocardiogram?
Of course, sir, I'll also advise for an echocardiogram, sir.
So good. And what medicine will you give when the patient goes home?
Sir, to control the rate, we can give, sir, beta blockers, sir, cardioselective beta blockers like metoprolol or bisoprolol can be given, sir.
Okay. And will you anticoagulate this patient?
Sir, according to the, sir, Chadva score, this patient scores, sir, 1, sir. So
Yes.
she doesn't have any comorbidity, so I will not advise for any anticoagulation if there is no structural heart disease, sir.
Okay. What do you think is the chance of this patient converting to sinus rhythm? Without, yes, without
if there
cardiofunction.
is, sir, if there is not any kind of underlying structural heart disease or, sir, any thyroid dysfunction, sir, the patient may be, sir, cardioverted without with only beta blockers, sir.
Yes. So fantastic. I mean, you did excellent. I mean, this is what I would have done. So this patient has palpitation, 6 hours, comes to the emergency room. I can give beta blocker. And if the rate gets controlled, the patient's CHA score is 1 because of the female sex. We may choose not to anticoagulate this patient and send home. The statistics is that new onset atrial fibrillation, more than 50% will convert spontaneously to sinus rhythm. If, of course, the rate becomes difficult to control, and we cannot keep the patient in the emergency room for many hours, we can admit the patient to the hospital, and we can wait for 48 hours. If within 48 hours it doesn't convert, then the strategy changes a little bit, because at that point we'll have to cardiovert the patient. So I think at that point, even if the CHA score is 1, we may consider short-term anticoagulation, not long-term, because there can be some stunning of the myocardium with cardioversion, and then discontinue. So, but the strategy was very, very simple. And a lot of these patients will never come back with atrial fibrillation. So now I have another patient. Okay, this is a patient with hypertension, history of congestive heart failure, ejection fraction 40%, and the ECG is this. This patient is a little different. She's 85-year-old, has her AFib with well-controlled ventricular rate. So this patient can be treated as an outpatient. I mean, this is a patient that we saw in the office. But the risk factor, the CHA score is age 2, 1, and 1. So CHA score is 4. And so this patient will have to be anticoagulated. Rate is well controlled. What I will do with this patient, that I'll anticoagulate the patient, and we will not put him on any additional medicine because the rate is already controlled. And then at this point, we give anticoagulation for 4 weeks, and then I can choose to cardiovert. This patient got amiodarone. It is an old time, 1996, got amiodarone for 200 milligram TID for 1 week, and then BID, and then got cardioversion because atrial fibrillation. But we could have chosen, ideally, what I would do is this patient, 4 weeks of anticoagulation, I'll cardiovert. If after cardioversion, there is recurrence of atrial fibrillation, then I will choose antiarrhythmic medication. Or if after cardioversion, the patient comes back within a month or so with AFib, then I will consider antiarrhythmic therapy. If this patient after cardioversion comes back to me after 2 years with atrial fibrillation, then I can just cardiovert again. But however, this patient received amiodarone, and then cardioversion. You can see that became sinus rhythm. And then, of course, the problem, not problem, once you start initiate amiodarone, you have to continue amiodarone. But not necessarily true. What you can choose to do is that you can try to discontinue amiodarone after a period of time, 3 months or 6 months. And then if they maintain sinus rhythm, then it's well and good. The other patient, 67-year-old male, renal transplant, routine ECG, totally asymptomatic, showed atrial fibrillation, slow ventricular response. The patient was not on any rate control medication, so the heart rate is really low. So what we decided at this point that we put a pacemaker in because we could not do anything on this patient without anything. So we put a dual chamber pacemaker. We started warfarin. In those days, it is older patient days, warfarin. We started sotalol, 80 milligrams BID, and then continued cardioversion. And what happened? The patient went to sinus rhythm, but then patient stopped sotalol, went back to AFib again, started sotalol, and did cardioversion again, and maintained sinus rhythm subsequently. And this is the ECG. You can see that AV sequential paced rhythm. And this patient must have some kind of AV conduction, otherwise it would not have paced the ventricle. So if you see the pattern is that if new onset atrial fibrillation, rate control, anticoagulation, cardioversion to normal rhythm, and then consider antiarrhythmic therapy. And so this is another patient who had intermittent palpitation since 1991. When you saw the patient in 1995, palpitation for 3 days, blood pressure was good, lungs feels clear, and ECG showed atrial fibrillation. So what we did, the rate is well controlled. We treated mild ventricular hypernormal ejection fraction. The valves are normal. And so we decided that we will, because the patient had long history of paroxysmal AFib, we started sotalol 80 milligrams BID, then converted to sinus rhythm with occasional palpitation, and we increased the sotalol to 120 BID and cardioverted, but remained in atrial fibrillation. So the question is, now this patient has failed antiarrhythmic medication. What to do next? And we tried class 1C antiarrhythmic. That also failed. We tried amiodarone and cardiovert. It failed. So if somebody fails to maintain or restore sinus rhythm even after treatment with amiodarone, this patient is not going to maintain sinus rhythm, and we are not going to send this patient for atrial fibrillation. What we do is that at this point, if this patient maintains sinus rhythm even for 7 days, we know that he has the ability to maintain sinus rhythm. And then we send this patient for atrial fibrillation ablation. But this is not an ideal patient. And so for atrial fibrillation ablation, there are multiple techniques that started with surgical maze procedure, catheter maze, but then focal AFib, and then, of course, now the procedure that is done in pulmonary vein isolation. Please remember that atrial fibrillation ablation is not like other ablations. Like if we take atrial flutter, if we take supraventricular tachycardia, the success rate of ablation is close to 100%. But pulmonary vein isolation, the success rate initially is 70 to 70%, and then multiple, some patients need multiple ablations. And on the top of that, a lot of these patients end up with antiarrhythmic therapy. I'm going to skip these things. This is one patient that had atrial failed quinidine, propofin, and amiodarone, and that Holter monitor showed that daytime there is marked tachycardia, and nighttime, of course, there is bradycardia. What we did this patient that we put a pacemaker and did AV node ablation. This is the ideal patient that has significant daytime tachycardia, difficult to rate control, and then nighttime bradycardia. So the other option in this group of patients, what we do is we don't immediately go into ablation. What we will do, we will put a pacemaker in and aggressively rate control them, maximize the medicine, calcium channel blocker, beta blocker. And if that controls daytime heart rate and nighttime, the pacemaker will help with the bradycardia. But of course, if that doesn't work, then we do AV node ablation. So AV node ablation will be something that will be the last thing. Main reason is that because the patients become totally dependent on pacemaker. So this is what happens that patient if with RVR, once we do ablation, they go into pace rhythm. It's complete heart block. And there are a lot of patients, the patients do well after AV node ablation. So we mentioned initially that spontaneous conversion rate is 40 to 50%, but who to cardiovert? All new patients with atrial fibrillation should be considered for cardioversion. And of course, if I find a patient who is totally asymptomatic, rate is well controlled, and we know that the patient has long duration of AFib and echo showed a large left atrium, in those patients, probably it is futile to consider them for cardioversion. A cardioversion, electrical cardioversion, and pharmacological is done. Ibutalat is a drug that we use in the emergency room to convert, mostly for new onset atrial fibrillation. But even after intravenous Ibutalat, we have to keep these patients in the hospital, and they have high rate of Torsades. Drugs like amiodarone, sotalol, they are not very effective in cardioverting patients. Most of them require initiation of the drug followed by cardioversion. One of the things that we have to talk about cardioversion, that cardioversion is not a complex procedure, but I always tell people, riding bicycle is not a complex thing, but you have to learn it. And you have to watch somebody do it, somebody have to teach you this. So if you are planning to do cardioversion, please make sure that you do not learn it on your own. You always should go to a facility. You can ask Professor Odud or one of the faculty, but look, I have some patients, I want to learn cardioversion. Can I come and work with you for a day or two? It's not a complex procedure, but you should do it under somebody's supervision, and you learn a lot of new tricks. It is true for anything new. I do not suture something without being taught by somebody. It's very, very important. And the other thing, that we need general anesthesia for this procedure because it's a very painful procedure. We will do without general anesthesia only when it is necessary. Absolutely necessary, that a patient's life is at risk. But remember, AFib ablation, AFib cardioversion rarely should be done emergently, because if you do it without anticoagulation, patient may end up with stroke. If you are planning to do a cardioversion in a place where you do not have anesthesia coverage, anesthesia department, then you should learn how to do conscious sedation. And I have talked to Adud and others from time to time about it. This is something that what we do, we all physicians in the United States, we have a training program with the anesthesiology department, and they teach us how to do conscious sedation. And we have to take this test every 2 years to make sure that we know the risk associated, what are the precautions to take, and you can do it. Please remember, these are all patients. And so timing of cardioversion. If it is permanent atrial fibrillation, we require at least 1 month of anticoagulation, and we can do cardioversion. If the duration is uncertain, then again, 1 month of anticoagulation and cardioversion. If the patient is unstable, then what we do a TE. Start anticoagulation immediately after cardioversion. And of course, if there is an acute patient comes in who is hemodynamic unstable and we need urgent cardioversion, we start anticoagulation, we do TE. If there is no clot, we do cardioversion followed by anticoagulation. If, of course, there is blood clot, then we have no choice. We have to anticoagulate 4 to 6 weeks, repeat, because if you see blood clot once, you have to make sure there is no blood clot after even 4 weeks, or at least it has organized, and then you do cardioversion. And so what are the drugs that we use for maintenance of sinus rhythm? Drugs, we can use quinidine. We don't have it in Bangladesh. Dicyclopramide, we don't have it. We have flecainide in Bangladesh, and we have propafenone, right? Yes, both of these drugs are available. These drugs are very good drugs. Only thing is that if somebody has structural heart disease, you cannot give this medication. So you have to be careful, make sure they don't have any coronary disease or any kind of structural heart disease. And then, of course, class 3 drugs, we have sotalol and amiodarone in Bangladesh. So amiodarone used in United States have gone down significantly, mainly because this drug has so much side effect. So you have to be very, very careful. Our drug of choice initially is sotalol. If that fails, then we use amiodarone. If it is an older person, we use amiodarone longer term. If it is a younger person, we try not to use amiodarone long term, because amiodarone is a drug that accumulates in the body, and 90% of patients are going to end up with side effects. And some of the side effects are irreversible. Like if you develop thyroid dysfunction, you become hypothyroid. That means by trying to cure one disease, I have created a new disease for the patient by just using this medication. So please be careful about use of amiodarone. It's a wonderful drug, but be careful about using it. When not to use antiarrhythmic? If somebody has one episode of atrial fibrillation, like my first patient, goes back to sinus rhythm, we don't have to use it. Or I have a patient who I cardiovert, goes back to sinus rhythm. We don't have to use antiarrhythmic. Second, paroxysmal atrial fibrillation, gets palpitation every few months, lasts for a few minutes, doing fine. We don't have to use antiarrhythmic. Or somebody who has underlying correctable cause, somebody like that correctable cause will be mostly hyperthyroidism. If somebody has hyperthyroidism and we fix it, then we don't have to use antiarrhythmic medication. I think, so just to summarize the thing, that if somebody has atrial failure less than 48 hours, then rate control, consider antithrombotic or anticoagulation based on Charles score, observe for spontaneous conversion. If they don't convert, what we do actually, that if they don't convert, we try to cardiovert before 48 hours is over, because we don't have to acutely, we don't have to anticoagulate if it is less than 48 hours. And if there is, and then we have to decide whether to use antiarrhythmic therapy or not. Now, if it is more than 48 hours, then we have done the strategy that anticoagulation for 4 to 6 weeks, and then cardioversion, and depending on type of the patient, use antiarrhythmic or not to use antiarrhythmic. And then if it is longer duration, you can actually individualize the therapy. But I don't believe that patient, if they have more than 1 year duration, should be deprived of a restoration of sinus rhythm strategy just because of duration, because they just didn't go to a physician. Nobody, or maybe saw a physician who did not care about cardioversion. I see patients like that. Thank you. I think we're going to stop here. And I think probably, so to summarize, for management of atrial fibrillation, the first key is the diagnosis. Second, risk stratification of stroke. Second, third will be treatment. Investigation, the key is ECG and echo. And if we do one blood test, that will be thyroid function test. And treatment-wise, we should rate control and anticoagulate first, and then make a decision and the timing to restore sinus rhythm and how to use antiarrhythmic medication. Thank you very much.
Thank you, sir.
Thank you. Sir, thank you very much for wonderful presentation. I think most of our audience learned many things from this presentation. First of all, I would like to go to our chairperson Wadud sir to say something about this overall presentation. Then we'll take some questions.
মতিন, আমি সেই ফর্মাল ওয়েতে কথা বলবো না। আমার মনে হয় যে কতগুলো খুব ইম্পর্টেন্ট কোশ্চেন এসছে, সেই কোশ্চেনগুলো নিয়ে আলোচনা করলে খুব ভালো হবে। তুমি দেখো চ্যাট বক্সে আমি একটু বলছি, যেমন একটা কোশ্চেন করেছে একজনে প্র্যাকটিক্যাল পারপাজে, যে a lot of patients admitted with atrial fibrillation with fast ventricular rate due to severe MS. Their BP is very low, pulse is feeble. Is it cardiogenic shock? How to manage it? Should we use inotrops for this patient to raise BP? Sir, your take on that.
No, that's your question.
I always teach my patients, if you see a patient whose BP you can record, but patient is still having some urine pass, that's not cardiogenic shock.
Yeah.
And you always pay attention to that. You will find most of these patients have severe MS. You can have patient, we have seen patients whose BP could not be recorded for 7 days or more. Still, the patient is surviving, taking food, very weak, but still surviving. Do not use inotrop. Because if you do the ECG, you will find out they have very fast ventricular rate. Here, digoxin is the best drug. And as these patients have congestive failure, most of the time oral digoxin is not absorbed properly, though it is a very well absorbed drug mostly. In that case, you can use intravenous digoxin. And if you control the rate, you will find out surprisingly the BP is getting up. If you use dopamine, you will just worsen the situation.
Yeah, well, thank you. I mean, the blood pressure, blood pressure, low blood pressure doesn't mean that patient is in cardiogenic shock. I mean, we have heart failure patients with blood pressure of 90, 80. And the key, of course, we have to get the rate down. In the ICU, I always tell the people to give 0.25 of digoxin IV 1 dose and followed by another 0.25 after 6 hours. And that works excellent and lasts for several hours. And as Wadud mentioned, that once the heart rate goes down, the blood pressure will improve. And inotrope, of course, will work totally opposite because it will make the rate really, really fast. Now, of course, if this patient really is in bad situation, blood pressure is dropping, you will have to cardiovert, but you will have to do transesophageal echocardiogram before you can cardiovert, and then of course with anticoagulation. Thank you.
Thank you, sir. Sir, another question from the Kamal Kormakar. If a patient come with acute STMI with atrial fibrillation with fast ventricular rate, can we use digoxin to this patient to control AF?
The question is, somebody comes with acute MI. I mean, it's two things going on. Acute MI is the primary event. And of course, you have to use beta. If the blood pressure is good, you can use beta blocker to control the heart rate. And I'm sure that this patient, once you intervene, if there is, depending on where we are, we talked about this, intervention is not available everywhere. We can get the rate down if we do thrombolytics. Eventually, the rate will come down because the patient is not that very sick. So this kind of questions, we always, I grew up learning by books, right? But the books and real life is different. And each patient is different. And I think you have to individualize those things. If the blood pressure is low, of course, you can use digoxin. I mean, 1 or 2 doses of digoxin will help, not harm the patient at all. Or any other modality of rate control.
Sir, can they use a amiodarone for that? Because people are afraid of using digoxin.
Yeah, but the question is, can I use amiodarone? Amiodarone is not a rate control medicine.
Yes.
Yeah, please remember that. Amiodarone is not a rate control medicine. Yes, you can use amio, you may feel good about it, but that's where we gather experience, that if you give amiodarone to this patient in your life, please see what happened. And then after 5 years, you realize that a lot of this patient did not get into. So that's how we learn medicine. That how do I learn it? Yes, one is from the lectures that Dr. Rafiq Ahmed gave, Professor Udit Chaudhary gave. Other is from my personal experience. So we keep a mental note of those patients. That is the most important learning process. We try to use amiodarone. I mean, it's too many drips in a patient who is coming with acute MI.
স্যার এই ক্ষেত্রে তো স্যার হচ্ছে আসলে ইসকেমিক হার্ট ডিজিজ বা এসটিএম এর পেশেন্টদের যদি হিমোডাইনামিক্যালি স্টেবল থাকে সেই ক্ষেত্রে তো স্যার আমরা অনেক সময় বিটা ব্লকার
Beta blocker.
এজ এ পার্ট অফ দি ম্যানেজমেন্ট অফ দি এমআই
Yeah.
সেটা
Intervention,
কিন্তু আমাদের রেট কমে আসবে স্যার।
primary
Of
PCI
course.
and beta blocker, that actually most of this always convert.
Absolutely. Absolutely.
Sir, another question from another participant: is there any difference in management of AF in COVID?
AF in COVID. Well, yeah, of course. I mean, the management principle is same. The substrate, the COVID patients have multitude of course, acute event. Some of them have pericarditis, probably, myocarditis, and that can cause it. But that management will be the same strategy for whether it's COVID or not.
Yes, sir. Sir, can we use antiplatelet in atrial fibrillation patient with low risk scoring?
Well, data is very, very simple. That if the score is 0, you don't need anything at all. If the score is 2 for females, 1 for male, you can choose to use antiplatelet therapy, aspirin. There is no other data. If it is 2 or more in male, 3 or more in females, clearly anticoagulation is the only thing that is beneficial. That has been proven again and again in it's much more older studies. Aspirin does not offer any benefit.
Actually, সবাই যেটা কনফিউজড হয়ে যায়, যে থেকে আমি যেহেতু এটা স্ট্রোক হওয়ার আছে, রিস্ক আছে, আমি অ্যান্টিকোয়াগুলেশন করার পর অ্যাসপিরিন দিব কিনা। অ্যাকচুয়ালি বা স্টাডিতে বলা আছে ইফ ইউ আর ডুইং ফুল অ্যান্টিকোয়াগুলেশন অ্যাসপিরিন দেওয়ার প্রয়োজন নাই, unless you have done some intervention.
Exactly. So only situation that you will add aspirin will be if the patient has stent. And that is the reason for anticoagulation. Oh, sorry, that is the reason for use of aspirin in those patients.
একটা কোশ্চেন এসছে যে ডক্টর হাসান তাসনিম করেছেন, which one is more difficult to manage, AF with fast ventricular rate or atrial flutter with fast rate?
My personal experience, it's easier to rate control fibrillation than
sir.
flutter.
Sir.
I'll tell you example. If you have 10,000 people inside Dhaka Stadium and you let a tiger loose, they will not be able to get out because they are going to jump into each other. But if they form line, they will be able to go out faster. That's the difference between atrial flutter and fibrillation. Atrial flutter is a very organized, and they either conduct 2-to-1 or 1-to-1. And medication-wise, we find it very difficult to rate control atrial flutter as opposed to fibrillation.
একটা জিনিস যেটা আমাদের এখানে স্যার আমার অবজারভেশন, যেটা আপনি খুব জোর দিয়েছেন, যে atrial flutter should be considered as bad as atrial fibrillation regarding particularly stroke and other things. আমাদের এখানে এটা খুব আন্ডার ডায়াগনোজ, আন্ডার ট্রিটেড।
Yeah, absolutely. I mean, it's the same. The risk factors, risk stratification should be based on the CHAS-BAS score. Clearly, no question about it.
Sir, another question to Sir Wadud sir. Sir, which one is the commonest cause in our context, sir, for atrial fibrillation?
আমার অবজারভেশন হলো, when I was a student and now I am a teacher, সিনারিও কিন্তু চেঞ্জ হয়ে গেছে। আগে কিন্তু atrial fibrillation মাত্রই আমরা সিনোনিমাস ধরে নিতাম 2-3টা রোগ। 1 নম্বর mitral valvular disease, number 2 hypertensive heart disease, uncontrolled hypertension, number 3 thyrotoxicosis, number 4 ischemic heart disease। আর কিছু পেতাম যেগুলো কারণ পাই না। কিন্তু এখন কিন্তু congestive cardiac failure and associated atrial fibrillation, we are getting a lot of patients because these patients are surviving. ICM patients are increasing in number, so we are getting a lot of patients with atrial fibrillation because of that LV dysfunction.
Thank you, sir.
Sir, আপনার comment.
No, absolutely right. I mean, what do you say?
এই রিলেটেড একটা কোশ্চেন, আগে যেমন স্যার আমরা ভালভুলার অ্যাট্রিয়াল ফিব্রিলেশন পেতাম, তখন আমাদেরকে বলা হতো স্যার ওয়ারফেরিন, নো রোল অফ ডোয়াক। কিন্তু এখন স্যার বর্তমান গাইডলাইন অনুযায়ী কি স্যার ডোয়াক বা নোয়াকের স্যার ভালভুলার অ্যাট্রিয়াল ফিব্রিলেশনে কোনো রোল আছে স্যার?
Well, the current guideline is moderate to severe mitral stenosis and mechanical valve gets warfarin.
Yes, sir.
Rest of them can be the newer anticoagulant. That's the current guideline. Because, a lot of patients have mitral regurgitation, but I think it's the mitral stenosis that's more important to consider as true disease that causes AFib.
এখানে একটা সিনারিও যেমন বলি, একটা পেশেন্টের টিস্যু ভালভ লাগানো আছে মাইট্রাল ভালভে, কিন্তু দ্য পেশেন্ট হ্যাজ অ্যাট্রিয়াল ফিব্রিলেশন, আমি কিন্তু এই পেশেন্টের জন্য লোয়াক ইউজ করব, কারণ যে টিস্যু ভালভ আছে তার জন্য কিন্তু আমার ওয়ারফেরিন প্রয়োজন নাই।
অ্যাবসলিউটলি।
আর আমরা দুই একটা লাইভ কোশ্চেন নেই মতিন ভাই, আমাদের অনেকে হ্যান্ড রেজ করে রেখেছেন। আমরা ডাক্তার জান্নাতুল ফেরদৌস, আপনি হ্যান্ড রেজ করে রেখেছেন, আপনি যদি আপনার কোশ্চেন লাইভ করেন। জান্নাতুল ফেরদৌস, জি আপনার কোশ্চেনটি করুন।
জান্নাত, আনমিউট করে কথা বলো।
ওকে, ডাক্তার সারাল রাজি, আপনি আপনার কোশ্চেনটা করতে পারেন।
আসসালামু আলাইকুম স্যার, থ্যাংক ইউ ফর দ্য এক্সিলেন্ট সেশন। স্যার আমার দুইটা কোশ্চেন, আমি শর্টকাট ভাবে করছি। প্র্যাকটিসিং ইয়েতে আমরা এখন যেটা দেখি যে রেট লিমিটিং ড্রাগস যখন দেওয়া হয়, দেখা যায় ডিগক্সিনের সাথে বিটা ব্লকার কম্বিনেশন অথবা মানে কন্ট্রোল হচ্ছে না রেট এক্ষেত্রে, অথবা ডিগক্সিনের সাথে রেট লিমিটিং ক্যালসিয়াম চ্যানেল ব্লকার, এক্ষেত্রে পেশেন্টদের আমরা অনেক সময় পাই ফ্ল্যাকচুয়েশন হয় স্যার রেটটা, আইদার হঠাৎ করে দেখা যায় 100 এর উপর উঠে যাচ্ছে অথবা দেখা গেল আবার ব্যাডি হয়ে যাচ্ছে 60 এর নিচে। এক্ষেত্রে স্যার আমরা কি মানে প্রসেস বা কি ভাবতে পারি, মানে ওইসব পেশেন্টকে কন্ট্রোলে রাখা, রেট কন্ট্রোলে রাখার ক্ষেত্রে আমাদের অ্যাপ্রোচটা কি হতে পারে স্যার, এটা একটা কোশ্চেন। আর আমার সেকেন্ড কোশ্চেন হচ্ছে স্যার, পার্মানেন্ট অ্যাট্রিয়াল ফিব্রিলেশন যখন আমরা কনফার্ম হয়ে যাচ্ছি যে পেশেন্টের পার্মানেন্ট অ্যাট্রিয়াল ফিব্রিলেশন ডেভেলপ করে গেছে, কিন্তু পেশেন্ট রিদম কন্ট্রোলের জন্য অলরেডি অ্যামিউটেরন পেয়ে যাচ্ছে, এক্ষেত্রে স্যার অ্যামিউটেরন কি চলতেই থাকবে বা আমরা অফ করতে পারবো কিনা, মানে আমাদের অ্যামিউটেরনের এক্ষেত্রে রোলটা কি থাকতে স্যার? Thank you, sir.
Thank you. Both are excellent questions. The first, I'll start with the second one. I saw two patients recently to this thing, that these patients were on amiodarone and maintaining standard, but whoever was following the patient for last 2 years, patient is in AFib and continued with the amiodarone. So what means they don't need amiodarone anymore. So I discontinued it. Or if I wanted to continue, I would try to attempt cardioversion. One patient was on amio, nobody even bothered to cardiovert. So I cardioverted and that patient is maintained. So both out of the two, one is maintaining sinus rhythm, other I just discontinued and rate control. The first question is the rate control. Of course, it's a problem. I do not consider any heart rate as a low heart rate unless the patient is symptomatic. So if the heart rate goes to 45, 50, that's not an issue. But also, if the heart rate is just around 100, that's not a bigger issue. But if I find that with minimal activity, patient's heart rate goes to 100, 120, 130, then of course you will have to do a better rate control. And if you find that in trying to get better heart rate control, you started having significant bradycardia, then you have to combine it with a pacemaker and aggressive heart rate control. If that answers your question.
আমি একটু এখানে একটু সাপ্লিমেন্ট দিতে চাই। এটা প্রবলেম হয় দেখবা যে এই পেশেন্ট গুলো যদি হঠাৎ করে দেখবা রাতের বেলা খুব বেডি হয়ে যাচ্ছে, দিনের বেলায় আছে, তোমার সেক্ষেত্রে তোমার ডোজটা ওইভাবে অ্যাডজাস্ট করে দিলে হয় যে রাতে কম পাবে, দিনের বেলা কম্বিনেশন সকালে পেলো, তাহলে কিন্তু কন্ট্রোল হয়। আরেকটা জিনিস আমাদের ধারণা ছিল এক সময় যে 80-র নিচে থাকতেই হবে, কিন্তু রিসেন্ট কিছু স্টাডিতে বলছে 110 পর্যন্ত যদি রেট থাকে, দ্যাটস অলমোস্ট ইকুইভ্যালেন্ট টু ভেরি কন্ট্রোল রেট। 70-80 রেট থাকা এবং 110 টাকার মধ্যে খুব বেশ কম নেই। কাজে ওই যে আমরা এত বেশি ওরিড হওয়া উচিত না, আনলেস দ্য পেশেন্ট ইজ সিম্পটোম্যাটিক।
Yes, I think what would brings up a very important point, that let's say you put a halter, sometimes the heart rate can be 30 at night, doesn't really matter. But of course, if we distribute that, then in those patients we can say take the beta blocker in the morning or calcium channel blocker in the morning rather than at night. But nighttime, we have a lot of patients with pauses. We just continue with the medicine.
স্যার এখানে আমার একটা অবজারভেশন আছে যে ইন দ্যাট কেস এখানে উই শুড চুজ এ ড্রাগ যেটা হাফ লাইফটা কিন্তু কম, তাহলে আমার লং হাফ লাইফের ইফেক্টটা রাতে থাকলো না। আমি ডিস্ট্রিবিউট করে দিলাম সকালে হায়ার ডোজ, রাতে লো ডোজ, এর থাকবে না।
Absolutely. I think that, this applies for a lot of scenarios, like hypertension. There are medicines which are single daily dose, but you find that the blood pressure before the next dose is high. And sometimes we give them BID, like lisinopril. Instead of giving 5 milligram once a day, I split it into 2.5 milligram twice a day. And likewise, if you are giving metoprolol tartrate, you can say, I'm going to give 75 milligram in the morning and 25 at night. And that will balance it out.
Yes.
আর আমরা আরেকটা লাইভ কোশ্চেন নিয়ে লাইভ কোশ্চেন শেষ করে দেব। সাজ্জাদ হোসেন রুমেল, অনেক সাজ্জাদ হোসেন রুমেলকে দেন।
Assalamu alaikum, sir.
Assalaam.
Thank you for the great presentation. I'm really honored to be a part of this. Sir, I have one question only.
Sure.
In the periphery, when we're practicing medicine in periphery, sir, sometimes we find patients who come with hemodynamically unstable atrial fibrillation, and there is no in nearby areas. So if we want to cardiovert this patient to save his life on an emergency basis, what should be our plan regarding anticoagulation, sir?
Well, this is the problem, because you see, that's again, you have to individualize the patient.
Yes, sir.
Let's say a young person comes to you, and unfortunately, the problem is if you cardiovert and the patient develops a stroke, that's a catastrophic event for you. Also, as a physician, it is a very difficult scenario. I mean, I think we are talking about a theoretical scenario, but I think I will still try to rate control this patient. Doing cardioverting a patient that I do not know, especially in a setting where you have no other control, and the consequence can be. On the other hand, if it is, let's say, I know this patient and very reliable patient suddenly goes into AFib with RVR, never had these, and based on my clinical scenario, we may choose to cardiovert. So it has to be, you have to individualize this care. But I'll tell you something, not only in Bangladesh, not doing something will, as a physician, will only give you the reputation you did not do anything. However, if you do something and it harms the patient, that will give you a worse reputation and put you in a very, very difficult situation. It's true even in the United States, not only in Bangladesh, and it's more so for the physicians. And I mean, we have to talk about physician violence towards physician. That is a problem in a lot of third world countries, not only in Bangladesh, and we have to be very, very careful about it.
আরেকটা জিনিস যেটা যে স্ট্রোকের পেশেন্ট যেটা মাইট্রাল অ্যাট্রিয়াল ফিব্রিলেশনের সাথে যে স্ট্রোকটা রিলেটেড থাকে, দিস এম্বোলিক material are very larger amount, so they create a huge area of particularly mid-cerebral artery. Whole mid-cerebral artery may get blocked. They have very large stroke, not a small stroke.
স্যার আপনার কাছে স্যার একটা কোশ্চেন নিয়ে যাচ্ছি। প্রেগন্যান্সি নিয়ে আমরা 2-3টা কোশ্চেন পেয়েছি স্যার, আমি একসাথেই করতেছি। In our rural area, there are some female patients with chronic pneumatic heart disease with atrial fibrillation of childbearing age. Should we start warfarin in them, as there is the fear of loss to follow up? And another related question, what will be our anticoagulation policy in pregnancy?
Yeah, so I'll have to have you join in. Anticoagulation in pregnancy, the newer drugs have no data. That's clear. Warfarin, there is some data. It is still teratogenic, and depending on the trimester of the pregnancy, you have to individualize the care. That at certain period, you have to use warfarin, and then you stop with warfarin and with heparin, and there are definite guidelines, you can look it up. So the care has to be individualized in this scenario.
দুটো জিনিস এখানে স্যার যেটা বলছেন, আসলে ওয়ারফারিন ছাড়া কোনো ড্রাগ ইউজ করা আর হলো কি যে আমরা লো মলিকুলার হেপারিনটা বা আমরা প্লেন হেপারিনটা ইউজ করতে পারি, সেটা তো প্র্যাকটিক্যাল না। ওয়ারফারিন আমাকে ইউজ করতে হবে, কিন্তু ফার্স্ট ট্রাইমেস্টারে আসলে কোনোটাই না দেওয়াই ভালো। বাট দ্য রিস্ক অফ ওই স্ট্রোক ইটস অলওয়েজ দেয়ার, ইউ ক্যান ডু নাথিং অ্যাবাউট ইট। ইউ ক্যান সাজেস্ট দ্য পেশেন্ট টু হ্যাভ ইন্টারভেনশন সো দ্যাট তার আদার কমপ্লিকেশনগুলো কম হয়। কারণ যখনই দেখা যায় যে মাইট্রাল ভালভ খুলে দেওয়া হয়, the chances of thrombus formation in the LA appendage কিন্তু কমে যায়। মাইট্রাল রিগার্জিটেশনে থ্রম্বাস ফর্মেশনের চান্স মাইট্রাল স্টেনোসিসের তার তুলনায় প্রায় 20 টাইমস লেস। এটা কিন্তু আমাদের মনে রাখতে হবে, কাজে এটা আমরা করতে পারি। দ্বিতীয় জিনিস যেটা আমরা কিন্তু মনে রাখা উচিত যে এইসব পেশেন্টে অ্যাট্রিয়াল ফিব্রিলেশনের জন্য রেট কন্ট্রোলার হিসাবে কিন্তু ডিগক্সিন কিন্তু সেফ, প্রেগনেন্সিতে কিন্তু ডিগক্সিন ইউজ করা যাবে, যেটা অনেকের ভুল ধারণা হয়। বরং এখানে আমি কিন্তু বিটা ব্লকারে ইউজ করতে গেলে কিন্তু কিছু কন্ট্রাইন্ডিকেশন আছে, বিশেষ করে উই মাস্ট নট ইউজ কার্বিডালোর।
So it's a very interesting point that what with my digoxin actually in pregnancy with supraventricular tachycardia, the drug that is recommended and interestingly it works is digoxin. The other drug that is not available is a very old drug, quinidine, for maintenance of sinus rhythm, has been proven to be relatively safe in pregnancy. So there are few drugs, warfarin, quinidine, and digoxin for rate control.
সবগুলো পুরনো ড্রাগ স্যার।
Yes, puronal drug, yeah, no question.
আজকে শেষ কোশ্চেনই আমরা শেষ করে দিচ্ছি স্যার। লাস্ট কোশ্চেন তো আমাদের রফিক স্যার, ডক্টর বদরুল আলম উনি জানতে চেয়েছেন, স্যার would you please tell the procedure of conscious sedation?
Oh, that's a big thing, but I think we need to talk about it. The conscious sedation, basically, the term means you are giving sedation, but the patient is still conscious. And as a non-anesthesiologist, we are only allowed to sedate enough that the patient will respond to me verbally. If I ask the patient, are you awake? They should be able to tell it. And we use midazolam and fentanyl, and we give it in a slow doses with resuscitation facility thing available. And we are very much aware what are the antidotes of those two medicines. So we have naloxone and the other antidote for midazolam available for us, so that if something happens, we can reverse it. And we have a clear protocol set up for this thing. I remember many years ago, we used to use diazepam intravenously. I mean, some of those patients will stop breathing. We were young and we had no experience. We did those things, but today I'm not going to do that anymore. I mean, some of them I could see that they would stop breathing, but I'm sure they survived because they were young patients. If same thing happened in older patients, they would probably not survive.
Thank you, sir. এই কোশ্চেন আনসারের মাধ্যমে আজকে আমাদের এই আজকের প্রেজেন্টেশন এবং প্রোগ্রাম আমরা শেষ পর্যন্ত চলে এসেছি। তো আমি আজকের এই প্রোগ্রামের স্পন্সর ছিল বায়োফার্মার অলবেনসিএম অলমিসাটান অ্যামলোডিপিনের সৌজন্যে এই প্রোগ্রামটি হয়েছে। আর আমি প্রথমেই বিডি ফিজিশিয়ানকে ধন্যবাদ জানাই, স্পেশালি এহসান খান ভাইকে, যে ওনারা এত সুন্দরভাবে এই ধরনের একটা প্ল্যাটফর্ম তৈরি করার কারণে আমাদের দেশ বিদেশের স্বনামধন্য চিকিৎসকরা আমাদেরকে অনেক কিছু শেয়ার করতে পারছেন, আমরা অনেক কিছু জানতে পারছি। তো আমি আজকে ওভারঅল প্রেজেন্টেশন এবং সবকিছু আমাদের পার্টিসিপেন্ট সম্পর্কে ইন শর্ট রফিক স্যারকে আরেকটু বলতে বলবো, এবং সবার শেষে ওয়াদুদ স্যার চেয়ারপারসন হিসেবে প্রোগ্রাম শেষ করবেন। স্যার।
Yeah, thank you all. I can see that still there are 75% in the focus, and thank you all for late staying this. Please continue with your, I mean, the education is the never-ending education, and we will never be perfect, but we all have to take calculated risk, but continuous studying is so important, that the medicine is such an ever-changing field that what I knew a few years ago is new now. And then again, we forget things. And these days, please use the technology, because if you are in a remote area, you can always reach a physician who has more experience. And the other thing is to share knowledge with each other. One of the things that we don't do in Bangladesh, that we do here, we always talk to each other. We at the same experience level. I even talk to young doctors. The reason I talk to the young doctors, because they come with newer knowledge and they teach me new things. And that's the beauty of talking to the young doctors, because they know more than I do, some of the things. I mean, I have more wisdom. So please continue culturing these teaching sessions, teaching, learning. Thank you all.
Thank you, sir. তো আজকের এই পর্যায়ে আমরা আমাদের প্রোগ্রামের শেষ পর্যন্ত চলে এসেছি। আমাদের এখন সর্বশেষ আজকের অনুষ্ঠানের চেয়ারপারসন অধ্যাপক আব্দুল ওয়াদুদ চৌধুরী স্যার, বিভাগীয় প্রধান, কার্ডিওলজি বিভাগ, ঢাকা মেডিকেল কলেজ হাসপাতাল, স্যারকে আমাদের এই প্রোগ্রাম সম্পর্কে ওভারঅল মূল্যায়ন এবং সবশেষে প্রোগ্রামটি শেষ করার জন্য অনুরোধ করছি।
ধন্যবাদ মতিন। আজকের অনুষ্ঠানটা সেই রবি ঠাকুরের ছোট গল্পের মতো, শেষ হইল না শেষ, অতৃপ্তিতে থাকবে, এবং সেই অতৃপ্তির কারণে আমরা আশা করব আরো বারবার রফিক স্যারকে আমাদের এই পর্দায় যেন দেখতে পাই, তার কাছ থেকে অনেক কঠিন জিনিসও যে কত সহজ করে বোধগম্য ভাবে সহজভাবে শেখা যায়, সেটা আমরা নতুন করে আরবার শিখি। এবং সবচেয়ে বড় কথা যেটা ওনার কাছ থেকে শিখেছি, যে ইনফরমেশন দিতে গিয়ে যেন আমরা ওভার বার্ডেন করে না ফেলি, সেটার জন্য আমার প্র্যাকটিক্যাল কাজে লাগার মতো হয়। ডে টু ডে লাইফে সেই জিনিসটা কাজে লাগলে পরেই আমি সেটাকে মনে রাখতে পারবো। সেটা শুধু বিদ্যা হয়ে থাকবে না, ইনফরমেশনগুলো তখন জ্ঞানে পরিণত হবে। আমরা আজকের প্রোগ্রামে 3টে জিনিসের দিকে আমি মনোযোগ আকর্ষণ করব। অ্যাট্রিয়াল ফিব্রিলেশনের ম্যানেজমেন্ট নিয়ে মতিন খুব কনফিডেন্টলি বলছিল মোর দেন 90% আমরা পেরিফেরিতে কন্ট্রোল করতে পারবো। আমার কাছে মনে হচ্ছে কথাটা ঠিক না। আমার অবজারভেশনে, যেহেতু আমি সারা দেশের রেফারেল পেশেন্ট দেখি, আমি এখনো দেখি অ্যান্টিকোয়াগুলেশনে আমরা সাংঘাতিক রকম পেছানো। নাম্বার 2, অ্যাট্রিয়াল ফ্লাটার ডায়াগনোসিসে আমরা সাংঘাতিক রকম পেছানো। নাম্বার 3, কার্ডিওভার্সন সম্বন্ধে আমরা যারা কার্ডিওলজিস্ট আছি তারা সাংঘাতিক রকম ভীতু, করতে চাই না। কিন্তু এটুকু বলতে পারি, এই অ্যাট্রিয়াল ফ্লাটার বা অ্যাট্রিয়াল ফিব্রিলেশনের পেশেন্ট যাদের কনভার্ট করেছি, আমি 80-র উপরে বয়সী পেশেন্টেরও কনভার্ট করেছি। এই স্যার যে বলেছেন সেই কনসাসিরেশন দিয়ে, যেহেতু আমার কাছে ওইরকম ফেসিলিটি অ্যাভেলেবল, এবং দ্যাট মিনস স্পেন্ডিং এ লট অফ মানি ফর দ্য পেশেন্ট পার্সপেক্টিভ, বাট দ্য রেজাল্ট ইজ ট্রিমেন্ডাস। এই যে টেকিকার্ডিওমায়োপ্যাথিতে যে পেশেন্টের হার্ট রেট থাকে 34%, সেটা যখন দেখা যায় 3 মাস পরে সেটা হয়ে গেছে 57%, এর থেকে আনন্দময় আর কিছু হতে পারে না। এই যে শেখানো প্রচেষ্টা স্যারের, সেটা কিন্তু আলটিমেটলি তোমাকে আমাকে অস্ত্র দিয়ে শানিত করার জন্য, যে অস্ত্রতে কাজে লাগবে রোগীর বিরুদ্ধে মানুষের উপকারের জন্য। তুমি, আমি, স্যার, আমাদের অডিয়েন্সে যারা আছেন, এসান, আমাদের সবাই কিন্তু এদেশের সন্তান। আমাদের সমস্ত প্রচেষ্টা যেন এই দেশমাতার কাজেই লাগে, আমি সবাইকে বিনীতভাবে সেইটুকু অনুরোধ করব। স্যার, আপনাকে অসংখ্য ধন্যবাদ। আপনাকে সবসময় ধন্যবাদ দিয়ে যেতে হচ্ছে, মৃত্যুর আগ পর্যন্ত দিয়ে যাব। শিক্ষকের ঋণ শোধ করা যায় শুধুমাত্র সেটা যদি আমি পরবর্তী প্রজন্মের কাছে এরকম কিছুটা শিখিয়ে যেতে পারি। আমরা আজকে যারা শিখছি তারা নিজেরা শুধু শিখবো না, অন্যদেরকেও এই শেখানোটা নতুন করে উপলব্ধির মাধ্যমে নিয়ে আসবো, আমি সেটা আশা করব। তাহলে রফিক স্যারের প্রচেষ্টা সফল হবে, তাহলে এহসানের প্রচেষ্টা সফল হবে। ধন্যবাদ সবাইকে।